cardiac surgery done. He is in the ICU. This is an ICU radiograph which is taken. It's of course a AP image. So what is an abnormality? Will you pass it as normal or abnormal? At a look. Yes, you can see this CP angles. The cardiac, the claustrophrenic sulcus is very deep. That is known as the deep sulcus sign. That is the sign you get in case of pneumothorax in supine chest radiograph. So how it collects is in the supine position, the most highest point of the pleural cavity is towards the base, either anterolaterally or anteromedially. In this particular case, the air has gone anterolaterally and deepened the CP, the claustrophrenic sulcus. So remember the deep sulcus sign for pneumothorax in the supine patient. Now after A, we have come to B, that is assessment of bone. You have to look at all the bones. Here you can see a widened rib on the left side. Now cardiac evaluation. So I don't tell much about it. I think all of you know how to measure the cardiothoracic ratio, and if the cardiothoracic ratio exceeds 0.55, you can diagnose cardiomegaly in a direct or a PA test radiograph. So this is a typical flower shape or globular heart of pericardial effusion. You can also see the narrow pedicle. Now we are reached to the evaluation of the diaphragm. So normally in a normal chest radiograph, the left diaphragm is at a lower level compared to right. And in a small percentage of patients, both diaphragms can as well be on the same level. So the right diaphragm can be said to be elevated. So the right diaphragm can be said to be elevated when the difference when the right diaphragm is at a height more than 3 cm from the left diaphragm. Then in case of left diaphragm, the left diaphragm can be said to be elevated when the left diaphragm is at a higher level than the right. Now whenever the diaphragm is elevated, look for any lesion below the diaphragm. Here, look whether the liver is enlarged. Then look any cause in the diaphragm and look for any cause above the diaphragm. Look for any parenchymal lesion or look for any mediastinal lesion which can involve the phrenic nerve. Look for any lesion in the root of the neck which can involve the phrenic nerve. Now we are coming to look for effusions. So these are 3 different patients, all with opaque hemithorax. So I can tell you a very simple way to analyze this. Just look at the mediastinum. So first case, where is the mediastinum? Mediastinum shifted to the same side. So no doubt you have to diagnose collapse in that case. Coming to this case, there is no mediastinal shift. And also you look carefully, you can see linear air containing structures. So these are the air bronchogram. The air, due to air within the bronchi, which are well seen because of the opacity. So if you see air bronchogram, that tells you that you are dealing with consolidation and no mediastinal shift. There is no volume loss. Coming here, the opaque hemithorax with mediastinal shift, that is a case of pleural effusion. Now we have come to the evaluation of the field and the mediastinum. So for the lung field evaluation, you divide the lung into 3 equal parts. And if the one side is normal, you can compare one side with the other. So in this particular case, if you compare one side with the other side, you would have found out some abnormality. Yes or no? Yes. You can come out with your response. That makes me very easy to present also. So there is some abnormality. This side is looking basic in comparison to this lung. This is more darker. So which lung is now abnormal? So if you have followed one of the points I have already raised, you would be able to come to a conclusion. Look, this is a female patient. So here I can see the breast shadow very well. So because of the breast shadow, the lower lung field is little hazy. And here I cannot see the breast shadow, which makes this lung more transradiant. It's a case of mastectomy for CA breast. Now, is it okay? I know the image is better without light. It's okay, they don't see me. It's better. Yeah. Yeah. Okay. So here, so in this case, you look at this is a mass lesion. I think you have no doubt. Now look at these lesions. These are quite diffusely irregular lesions, having the appearance of a cloud, and this is due to filling of the alveoli with either fluid or hemorrhage. So these are known as alveolar opacities, and these type of alveolar opacities we may see in pneumonia, commonly seen in pneumonia and in pulmonary edema and hemorrhage, pulmonary hemorrhage or confusion. But you can also see such type of lesion in bronchoalveolar carcinoma as well. Now, this case, I think all of you will make a diagnosis of pulmonary edema with the central perihilar opacities, and the cardiac margin is not well seen. This is the alveolar stage of pulmonary edema. So, we will be able to catch hold of pulmonary edema even earlier at the interstitial phase of pulmonary edema. So for that, you have to look at the periphery of the lung, towards the pleural surface periphery in the lower lobe region. If you look carefully in your image, you can see thin linear lines which are 1 to 2 centimeter long, which is perpendicular to the pleural surface. They are known as curly D lines. And these lines are due to fluid filling the interstitium. That is the intralobular interstitium. So interlobular interstitium, this is how the thickened interlobular interstitium appear on a like a polygonal shaped thing. Interlobular interstitial thickening, and so it indicates interstitial pulmonary edema. You can see fluid in the fissure, and also you can note the upper lobe diversion of blood flow. These are evidences of pulmonary edema at a stage earlier than the alveolar pulmonary edema. Now, this is just to show a solitary pulmonary nodule. There are many things to be looked, but most of the often we go in for a cross-sectional imaging when it comes to a solitary pulmonary nodule. Now, in the field evaluation itself, I would touch upon mediastinum. Now, there are certain obvious mediastinal lesions which will leave behind no difficulty to diagnose. But sometimes it may be difficult when a parenchymal lesion is seen close to the mediastinum, closely abutting the mediastinal border. You are in doubt whether it is mediastinal or parenchymal. How you can solve the issue? Now, this case, first look at the interface the lesion makes with the adjacent lung. If the interface is very sharp, that favor it to be mediastinal. Now, second point is you can see the tracheal shift in this case. If you see tracheal or mediastinal shift, mediastinal mass effect, that tells you that you are dealing with a mediastinal mass. Parenchymal lesions cannot produce mass effect and cause shift of the mediastinum. So, by these 2 points, this is mediastinum. But when it comes to this lesion, the interface the lesion makes with the adjacent lung is quite irregular. So, this is likely that this is a parenchymal lesion which is closely abutting the mediastinal border. Now, coming to this point, there is a upper lobe lesion, medial margin merging with the mediastinum. You are in doubt whether it is mediastinal or parenchymal. Here, look carefully, you can see some linear air containing structures which I already said are air bronchogram. So, if you see air bronchogram, it's consolidation and it is parenchymal. But the reverse is not true. If you do not see air bronchogram, you cannot tell that this is not parenchymal. because you can even have fluid bronchogram. So be beware of that point also. Now, once you have found out that your lesion is mediastinal, you can find out whether the lesion is in the same plane of the heart or posterior to heart by applying the Sinhout side. Now, if you look here, you are able to identify the beautiful contours of this lady just because this fold is painted black. Suppose I paint the entire thing white, you will not be able to appreciate the contours. Same is that is the principle of Sinhout side. So you are able to see the cardiac border because you have the air in the lung which is outlining the cardiac border. If I take out all the air, I will not be able to see the cardiac border. So there are two different cases. We will analyze it. I can see cardiac border very well. That means there is air in the same plane of the heart. The air in the plane of the heart is not disturbed. So this lesion cannot be in the same plane of the heart, and it is posterior. Now, in this case, I cannot see the cardiac margin. That means all the air in the plane of the heart is removed by the lesion. So this lesion has to be in the same plane of the heart. So once you found out whether it is in the same plane of the heart or posterior to heart, you can formulate your differentials. Now, this is a very vast topic. I may not be able to unveil the entire thing within the stipulated time, so I will be touching upon important things. Now, this is at enterprise. Would you pass it as a mass or a parenchymal lesion? Yes, some response? Yes? Parenchymal lesion, good. So, we can see this is a typical appearance of consolidation. I can see air bronchogram also. So, here it is touching the cardiac border, inseparable from the cardiac border. We can apply the Sinhout side in parenchymal lesion also. So you want to know which segment, which lobe is involved. So I cannot see the cardiac border separately. So that means all the air in this region of the heart is removed by that lesion. So if you go to this picture, you can see it is a middle lobe which is placed near to the right cardiac border. So this lesion has to be in the middle lobe. So that is a middle lobe consolidation. Now look at this lesion. Can you see the cardiac border? Yes or no? Yes. That means this lesion cannot be in the middle lobe. It has to be in the lower lobe. Now yet another case. I can see the air here. In this area, it's bright and there is no air in that area. Apart from that, another finding is that I can see a clear-cut margin, straight margin for the lesion laterally. Now here, if you look, there is no air, there is a clear-cut line margin. So this line margin is actually the horizontal fissure. We have already seen the normal position of the horizontal fissure. It runs from the hilum towards the axilla. So that means it has gone up, and it got displaced. It is displaced anteriorly. So that means there is volume loss. So the fissure is displaced and also there is loss of variation. So this is exactly the appearance of right upper lobe collapse consolidation. There are some other ancillary findings. You look at the diaphragm on either side. Diaphragm is elevated on the right side. You can also see compensatory overinflation. Now, next, in the field itself, I have shown you the alveolar densities of infection or hemorrhage. Here you can see some densities, but they are linear or reticular. This is how interstitial densities appear on the chest radar. Now, these two patients are COVID positive. This is a typical florid COVID case with the ground glass densities. And the second case also was COVID positive. But if you look at the image, we are seeing well-defined nodular lesions which are more towards the lower zone. So that picture of that second case does not suit for a COVID lung appearance, and this appearance is much suggestive of metastatic lesion in the lung. It is seen more towards the lower lobe and towards the periphery of the lung. That is a typical description. And this patient, after the COVID, she recovered, was found to have CA esophagus with multiple lung mets. Now we have come to the evaluation of the great vessels. You evaluate the pulmonary artery and the descending thoracic aorta. I cannot see the shadow of the descending thoracic aorta here. This is the descending thoracic aorta, that is a right-sided aortic arch. Now, you have to also evaluate the gastric bubble, which is seen just below the left diaphragm. So, it may indicate that patient absence of fundic bubble may indicate some sort of esophageal pathology in the correct clinical setting. Now, we have come to the letter H, that is evaluation of the hidden areas. So, always pay special attention to the epiphysis of the lung, which may be sometimes hidden. Pay attention to the hilar region, and always look through the heart to find out some retrocardiac pathology, and always look below the diaphragm. Now, in this particular case, I think you can see an air fluid level through the heart. So, there is some air fluid level in the retrocardiac region. So, it can be from a structure which is behind the heart, which has got air. Which is that structure which can have air behind the heart? Normal structure, esophagus. So, this can be due to some esophageal pathology, like even hiatus or whatever esophageal pathology in which esophagus is dilated. Now, or you have lung behind the heart. Lower lobe is there behind the heart. If you have got a lung abscess with an air fluid level, again you can have this air fluid level in the retrocardiac region. Now, the diaphragm, when you look at it in the frontal projection, you see it as a penciltron line. In fact, it is not. It's actually, in the real sense, it has got different domes. So, the lower lobe lesions can even be projected below the diaphragm. So, be careful. This patient had a lesion in the lower lobe which was projected below the diaphragm, which was missed in many a time it was missed. Finally, by the time it was found out and CT was done, it was quite late, it was a bronchogenic carcinoma. Now, this is just another chest X-ray, an image of which I want all of you to carry with you. Now, this is in the evaluation of field. Have you seen any abnormality? You divide it into 1, 2, 3. Any abnormality? This one? Yes. So, here, when compared to this side, there is some vein-like opacity over here. Okay? And also, if you look in the evaluation of D, the diaphragm is elevated. These are the two findings you have. Now, going back here. This is the typical appearance of left upper lobe collapse. So, it's a very tricky X-ray. You do not get a straight line here which you see in right upper lobe collapse. It's very easy to diagnose right upper lobe. Here we do not have the oblique fissure. So, only abnormality you may see is just a vein-like opacity and the diaphragm may be elevated. So, you have to make a diagnosis of left upper lobe collapse with it. Here, the fissure which moves is the oblique fissure in the left upper lobe, and the oblique fissure usually will not align tangential to the X-ray beam. So, we will not get a well-defined lower margin for this case. So, please carry this image with you so that you don't miss any case of left upper lobe collapse. Now, you have a peripheral lung lesion. So, is it in the lung or outside the lung? That is a question for which you can apply the pregnant lady sign. So, this is the pregnant lady over here. If you trace it and find out the angle it conferred with the adjacent pleura, that is more than 90. So, if the angle conferred by the lesion with the adjacent pleura is 90, you are dealing with a lesion outside the lung. It can be lesion in the pleura, it can be lesion in the rib or anywhere in the chest wall. So, if that pregnant lady sign is positive. Now, in contrast, this lesion, which is peripherally placed, you find out the angle between the lesion and the adjacent pleura. Is it 90 or less than 90? So, it is a parenchymal lesion. So, that is how you identify. Now, finally, we have come to the final stage. I am giving a chest radiograph. Can you just go quickly from A to H and find out what is the abnormality? I'll give you 1 or 2 seconds. Anybody can come up with the diagnosis. Yes? If I give you a clue, just look at B, go for B. B means bone. Just evaluate the bone. Just look at the bony structures. Very good, very good. Yeah, it's extremely very good. That means she has followed whatever I have said. See, the left clavicle is not seen here. This is a child. And if you look carefully in the evaluation of F, that is field, you can see some densities over here in the apical region. So this poor child had a evings of the clavicle, which was post-operative removed, and this is post-operative picture. He also had radiation. That is why there is some fibrosis in the upper. It's very good that somebody answered it. Now, I have told you to follow an alphabet-based approach to analyze a chest X-rays. So my request is that you can go from A to H, but don't stop in between. So even if you have found out a abnormality at point B, don't stop there. Keep running up to H. There may be multiple findings at the end of which you may be able to come to an amicable diagnosis in your case. But I also want to remind you that sometimes lesions outside the lung, there's a large chest wall lesion which may cast shadows in the chest radiograph. So be careful also to make an assessment of the patient. So, well, I am thankful to the organizing team for giving me this good opportunity to interact with this august audience. I am very happy that at least you could come out with an answer at the end. I am so very happy. And also to the audience who are listening so carefully, I am thankful to all of you. And incidentally, my great happiness in coming here today was that I could meet Dr. Pradeep Pidanu, illustrious son of a still more illustrious father, and it so happened that my father is a great friend of his father. I am so very happy today. So thank you all of you.
The floor is now open for questions.
And in assessing CT ratio, at what level do we take transverse thoracic?
So you have to take it as the largest transverse diameter. So you have to take the largest transverse diameter of the chest. Has to be taken. So rib for fracture, whichever, if suppose you are taking chest X-ray PA view, that means the anterior ribs are close to your imaging plate. So anterior ribs will be better seen on the PA chest radiograph, and when you take AP radiograph, the posterior ribs will be close to the imaging plate and it will be better delineated. Sometimes you may have to take oblique views as well to delineate the rib fracture. So it is good that you give your area of suspicion to the radiographer when you send them for X-ray so that they can do accordingly.
What do you suggest? Like now we have digital X-rays.
Yeah.
So do you specify that I want to have a look at the ribs, I want to rule out rib fracture so that the ribs are more protected than the soft tissue?
Yeah, sometimes you may have to, that they can adjust in their digital image so that the X-rays are better. They can adjust the contrast in their in the computer and make the X-rays better visible and give better contrast to the X-rays when they give you the images. So if you tell them like that, tell that a suspected case of rib fracture, they can project that area, the ribs, by adjusting the contrast in the image.
pulmonary embolism?
Pulmonary embolism, there are some findings in pulmonary embolism in case of plain X-rays. One thing is, few of them I can tell, that is pulmonary arteries will be enlarged. And another thing which you look for in the field evaluation, I said divide it into three. That lung will appear more transradial, more dark. That is, blood supply will be less. So that lung will appear more dark in color. So that is known as a pulmonary oligemia. So you can look for enlarged pulmonary arteries, you can look for oligemia, you can look for pleural effusion, and in full-blown case, once an infarct has set in, you can see the peripherally placed wedge-shaped infarct.
Thank you, ma'am. You have indeed set the tone for this new trend-setting basic radiology workshop. I now request Dr. Harikumar Nair sir to present a memento to Dr. Laly.